So what was your question?
So I went to your Instagram because I wanted to word it exactly how you worded it. But you said that you were things that you were treating today, and you had a whole list of them. And one of them was the lifelong sense of being unable to connect with others.
Yeah.
And I found that really interesting.
The reason this is hard to answer like in an Instagram format is that I kind of have to explain at least the basics of the whole traditional East Asian medical psychiatric model. So
Mhm.
I am gonna try to do that. so this is a this is a system that has resisted translation for centuries, and like, you know, tons of scholars who are way smarter than me have been confounded by it. But I, in my hubris and insanity, will attempt to translate this into some kind of like vaguely understandable terminology in the next half hour. So good
Let's
luck.
do it.
Yeah, no pressure. So like I'm basically just going to talk about this in the way that I understand it, to like clinically, like the way that I understand these terms so that they're clinically useful in helping people in my practice. So first of all, like just a little bit of background, like it's important to understand that the discipline of psychiatry, psychology, mental and behavioral health in traditional East Asian medicine is millennia older than that discipline in Western medicine. So like Western mental health as a discipline really traces its birth to like the 19th century. Like it's a very young discipline in the West. I mean, before that, it was pretty much just like you were, you know, it was the fault of your ovaries, madam, and you should get you to a sanitarium, and your husband will, of course, remarry. But you know, or you were like possessed by demons or something. And like we had a phase like that too. It was wild. But so you could get as far back as the Huangdine Jingling Shu and Su Wen. That's the Yellow Emperor's Inner Classic, which is like Han Dynasty. So we're talking like 220 BCE to 220 CE, in that range. And they're talking in a very sophisticated way about mental health complaints and how to treat them. That's the background. The first important thing to understand is that we don't differentiate between physiological and psychological symptoms in East Asian medicine. Every physiological system in the body has an emotional and psychological system that correlates with it, and vice versa. So you can see physical symptoms and diagnose an emotional problem, or you can see an emotional symptom and diagnose a physical problem. Usually they ride in the same cart, and you can treat one, get results in the other, treat the other, get results in the one. Our model of understanding the psyche, the way that we image it in East Asian medicine, is we posit this model of 5 basic emotional functions. These in Chinese, and I'm going to butcher the Mandarin here, so I apologize, are Nu, Shi, Yi, Bei, and Kong. So these are those terms that resist translation the most. And the reason for that is that our words for emotions in English are pretty binary, you know, happy, sad, calm, upset, things like that. Whereas these are best understood as spectra and continua. The whole idea is that you want, like the picture of mental health in this case looks like a balance among those 5 responses. When I explain it to patients, I tell them to think about a stereo system. You know, you want your bass and your treble and your mid-range and all these things to be nicely balanced, so one is not drowning out the others, so you can hear all of them clearly, right? So that's our picture of what mental health looks like. All of our pathological models, we plot all of that on a spectrum between excess and deficiency. So, and that works with these cognitive emotional systems as well as the physical systems, rather. Like we can use this case as an example to understand the whole thing. So we're concerned in this case with the function of Bei, which often gets grossly oversimplified in translation to like grief or sadness. But when you read about its clinical implications, it's almost always in the context of an interpersonal relationship. So they'll talk about grief of having lost a mother or a father or a sister, one of those primary attachments, and it ramifies into one's ability to form attachments later in life. Just as in Western mental health theory, we have the concept of the primary attachments and how those inform all of your attachments later in life. That's why they're so important. That system relates to all of your interpersonal relationships. Let's say that 0 is the most severe deficiency and 10 is the most severe excess. 5 on that spectrum is perfect mental health. Almost nobody, I have yet to meet a perfect 5. This Bay system, I find most clinically useful to translate it as like independence on the most deficient end. This is going to sound weird.
Okay.
And codependence on the most excess end. So it's your whole system of forming attachments and forming relationships, forming connections. And if that system is severely deficient, you have your classic sociopathic antisocial personality disorder, this person who cannot relate to others, cannot even conceptualize a relationship to another person, cannot even conceptualize other people as properly existing. Okay, cannot
Yep.
conceptualize selves other than the self. Okay,
Mhm.
so this would be a case of severe deficiency, we would say. The 10 would be the person who can only define the self, where the self gets totally subsumed by their relational identities. So the person who can only identify him or herself as this person's mother, this person's wife, this person's father. You know, I'm not myself, my individuated identity doesn't matter. It's only in my relationships to these other important people in my life that I identify. So, and this is a pathological state as well. This is the person who stays in the abusive relationship their whole life because I just don't know who I would be without this person who treats me like dirt under their fingernails or something. In the case of this patient, we had a situation where there was trauma early related to those primary attachments. There was abuse from the parents or abuse, neglect, something along those spectrums. The patient didn't go into detail. And the nice thing about this model and this system is that they don't really have to. You know, one of the biggest barriers to Western mental health methods, to talk therapy, things like that. And I'm a huge proponent of talk therapy. I always want to know when I'm treating a mental health concern that the patient is also seeing a therapist. I always want to get it from both angles if I possibly can. The principal barrier to that way of treating the thing is that you're having to use the mind, which is in a pathological state at this point, as your primary point of leverage to fix the mind. You are asking the patient to, okay, now I need you to articulate your feelings. We need to talk about these things that you're very resistant to talking about. And, you know, a good therapist, of course, will be able to find ways around that most of the time. You know, as any clinician knows, you can't get it 100% of the time. It's a nice tool. The East Asian medical model is to get to those cases because the patient doesn't really have to talk about it, doesn't really have to go into the details of those subjects, like these primary traumas that may be incredibly difficult, sometimes impossible for the patient to talk about. Other times they've, you know, repressed them so deeply that they couldn't talk about them if they wanted to. won't even acknowledge them in some cases, because we spent millennia looking at these cases and writing down the symptoms that we saw, the observable phenomena clinically. So, okay, if you have a patient who is super deficient in this function of Bay, their pulse will feel like this, their tongue will look like this, the abdomen will feel like this, they will report problems in these other systems. So the physical symptom that's correlated with Bay, or the physical system rather, they really should do something about those two words being so similar, encompasses the respiratory system, also the skin, also some functions of digestion. So tricky there. But very, very often you see people who have had issues with these fundamental attachments or have lost one of these fundamental attachments recently, where they will have issues with respiration or olfaction, or they'll develop a skin problem that has no other etiology. I published a very similar case recently where an elderly gentleman had just lost his wife of some 50 years, and his chief complaint was loss of taste and smell. And we treated
Not COVID related.
What's that? Not COVID related. Yes, we ruled that out first, obviously. But yeah, had the loss of taste and smell for like 5 years. So,
Right.
it would be a medical miracle if they had COVID. They would be patient zero, right? So yeah. So that's kind of the nice thing about this model, is you don't have to make the person talk about it. You don't have to have them articulate it perfectly. We have other ways of getting at it. So in terms of treatment, we have these, we have a series of points on the back that correlate to these 5 basic emotional responses. And we can apply different stimuli, whether it be an acupuncture, needle manipulation, whether it be cupping, whether it be moxibustion. We have all of these different stimuli that we can give to these points to regulate those systems in the way that we want them. So if this is a situation of true deficiency, we would apply a tonic stimulus to the point corresponding with the system that's deficient. So, in this case, we might do, we might apply a tonifying needle technique, needle stimulation to this point. They all have very fantastical sounding names. The point dealing with the system that we're talking about is gate of the corporeal soul. So you would apply a tonic stimulus to that point, and hopefully it would help regulate the system in conjunction with talk therapy, in conjunction with other points, treating other related physical ailments that the patient may have, and that's sort of the treatment model.
Makes a lot of sense. I have a question then about when you're talking about somebody who does not want to talk about any of the trauma or even admit that there's an issue.
Mm-hmm.
How would this treatment, I don't want to say better than, because that's not the case, but different than a Western model of talk therapy?
So yeah, that's the nice thing. And I've had this many times with, often it'll be pediatric cases. I had a little boy once who came, I call him the Incredible Hulk, because he came for, his mom brought him for anger, for rage, pure rage. And he would go off, it was like poltergeist. I mean, the kid would run around the house, break things, scream, yell. It was always for the mother. The mother was the lucky one who got, the rage. She was obviously the person the kid felt safe with. So he let it all hang out around her, So, and of course she brings the kid in, and I'm like, okay, what's the problem? And he's like, I don't have any problem. She brought me here. What do you want? So you bypass that whole process. You just feel like, I would just need to feel the pulse, get a general presenting complaint, in this case, probably from the parent. and feel the abdomen, look at the tongue, ask a few questions, generally about physical things. So do you sleep well? How's your digestion? Do you ever feel XYZ? You have pain in such and such a place. People are generally more comfortable talking about those things. Um, and it's interesting. The thing that often works against uh, patients understanding what we're about, in this case, actually works toward the patient being okay with what we're about, because we're asking questions that seem like they have nothing to do with the problem.
Right.
So that makes the patient feel safe a lot of times.
That makes sense.
Yeah, I mean, so they'll tell us things, and we can observe things about these people. I mean, so in the case of a person who had this severe deficiency with Bay, or one of these problems with this system, we would look for a history of asthma. We would look for a history of skin problems. We would look for a history of fatigue of a certain presentation. We would feel the pulse, feel the abdomen, look at the tongue, look at the posture, look at the breathing pattern, things like that. And that'll tell us most of what we need to know. We don't need to get into the nitty gritty of, how do you feel, and so they can deny that there's a problem till they're blue in the face, and we can still treat the problem. And the nice thing about it is that after you've established a rapport and established some trust by not always poking the bear like that and not always poking the sore spot, the person will often open up and will talk about it. If and it's the treatment itself is helpful in this regard, because we're dealing with the very system that's making it difficult for them to talk about it.
Right.
Yeah.
So have you, if we took the boy who came in with the anger issues,
Yeah.
he eventually recognized, oh, I really do
Yeah.
this to my mom? Does he?
Yeah. I mean,
Okay.
the first thing, bear in mind, once again, the first thing I did when he came in was refer him to a good therapist who was able to help him out. I find that for whatever reason, patients are more open to listening to me when I say they should see a therapist rather than a therapist when they say they should see a therapist. And I'm like, okay, I guess you're cool with me sticking needles in you and lighting you on fire and putting cups on you, but talking about your stuff is a bridge too far.
That's the difference between the physical
absolutely.
and the mental. Absolutely. Yeah.
Absolutely. And I mean, I will, so this happened in this particular case where they had gone to see a therapist at one point and the kid had not been receptive. I think there had been a chase involved. The guy the little guy was not feeling it at all and just bounced, and yeah, it was not a good scene. So I was able to talk to them and say, look, I know this therapist that I think would be a really good fit, and just give him a try. And working in conjunction with him, I was able to treat it from my end to the point that he got better, and he was able to eventually recognize that this was a thing. I mean, with kids, a lot of times it's and it really I shouldn't even say just with kids, with patients in general, they don't have the language to talk about it. I mean, we don't really give people that in our culture, and Chinese culture is no different. The reason we have these pretty sophisticated models to treat these things is because Chinese culture historically has been incredibly repressive. And so the tendency will be to somatize all of your psychiatric stuff. So for example, you'll read in that's the fun thing about practicing 3,000-year-old medicine, is that you get case studies from the 1200s and stuff like that. And so you read in these cases so and so had a timid gallbladder. you know, which is me like they're saying that the person has difficulty asserting themselves.
Mhm.
Or, you know, they'll say, uh, you know, for example, like the person has an overbearing liver, which means that they're kind of a dick. They're like they get angry easily. They insert themselves. They have mansplaining disease, you know.
Mhm.
So um so that's kind of the bent that it takes culturally, and you find Americans who do the same thing, you know. I have patients who clearly have been dealing with there's some severe trauma. I mean, you're in this game for a while, you get to know what you're looking for,
Mhm.
and you know, it's clear as day, but they're not copping to it, they're not aware of it, and so they
Might have
will,
repressed it.
well, right, and or they're just they can't conceptualize it, they can't get their brain around it, and so it will present physically. So like I had a patient, for example, who had a sciatica unexplained. And, you know, I dig, okay, was there an injury? Was it like this? Was it like that? No, nothing. No, it just woke up like that one day.
Mhm.
Okay, when did this start? Oh, a couple of years ago. Okay, what happened? Anything significant happened in your life a couple of years ago? Nah, I retired. Like, okay. So, all right. So why'd you decide to retire around that time? No, no reason in particular. Just felt like it was time. And then my favorite, often they'll drop it on you like on the way out the door.
You're right.
Like you've already done the whole thing and you're like scratching your head and I don't know. And like right on the way out the door, I remember this patient being like, "Oh yeah, you know, I don't know if it makes any difference, but like I saw my best friend drop dead right in front of me about the week before I retired. See you next week." Like,
Right. Right.
like,
Yeah.
okay, you didn't think about mentioning that? Maybe like but like often it
And with
will
that
be,
bomb.
yeah. So it'll be that kind of thing. So yeah, does that answer your question?
Yeah, it actually helps a lot.
You don't have to start with needles. Needles are just the most efficient and direct way to get leverage on that system. Usually, with really needle phobic patients, I will start with body work and cupping. And cupping's a really good way, like, because when you have, so there's another, this gets complicated quickly, but there's one of these emotional systems, these functional emotional systems that I was talking about, is a system called GAN, and its job is to regulate the transitions between these emotional states. Right, it's sort of the dial on your stereo. All right, so like GAN ensures that you can transition smoothly and proportionately between emotional states in response to stimulus. Okay. So like this is the reason that, like, you know, you stub your toe and you say, and you yell out and you go on about your day. If GAN is not functioning properly, you will stub your toe and you will have a nervous breakdown, or you will stub your toe and your whole day will be about that you stubbed your toe. You get stuck in
Mhm.
that emotional state. And that is the thing that has happened in this case with Bay. This person is stuck in that place. So in terms of when we deal with situations of what we in East Asian medicine would call blood stasis, spasm, or a circulatory block, poor circulation, we treat it often with cupping because it strongly moves the blood in a particular area, creates a pumping action on the circulation. So often we find that cupping these points as well will sort of I hate to use the word break because it's not so
I know.
violent, but will shake the person or break the person out of this stuck sort of place where everything is kind of bound up and they don't want to talk about it. There's no problem, you know. Yeah, I get this with a lot of my my elder men of New England who you ask them how they are, and they're always fine.
Fine.
And very often, like after I do some body work and some cupping, the patient finds that the acupuncture is much more comfortable, often pleasantly surprised by how not painful the acupuncture is. I mean, they'll barely feel it.
Right. I mean, I know this.
Yeah, especially in the
But
upper
it's,
back like that. Yeah. Oh yeah, it's getting over those points in particular are really good for patients who don't like needles or afraid of needles, because they don't have to see them either.
yeah, that's true. And that's broader. It's on your back. It's not, in a toe or,
Yeah.
it can be more sensitive. When you have somebody resistant to treatment, period, do you find that they become, will it still work if they're resisting?
Absolutely.
Because in Western medicine, it won't.
So that's not entirely true, because psychology in traditional East Asian medicine is much closer to psychiatry in the West than it is to psychology. Meaning, so if you think about, for example, psychoactive medication, it works the same whether the person is, wants it to or doesn't,
Yes.
or acknowledges that there's a problem or doesn't, to a degree. I mean, like, I'm sure I'm willing to bet that if you did like a study of that, you would probably find that patients who were receptive to medication working would probably have better outcomes than patients who weren't, but there is still an effect there.
Yeah.
So yeah.
That answers my question.
Thank you for allowing me the opportunity to ramble about this in your face.
Well, I mean, honestly, it's going to help somebody else too.
I hope so. I really hope so.
Yeah, it will.